Welcome, future nurses. Listen, if you're gearing up for the NCLEX, you know post-op care is a huge topic. So in this explainer, we're going to break down everything you need to know about caring for a patient after a hypophysectomy. My goal is to help you walk into that exam feeling totally prepared. Okay, let's just dive right in with a classic NCLEX-style question. Imagine this. Your patient, fresh out of surgery, says they have this weird, sweet-tasting drip in their throat. What's your first move? We're going to come back to this, but keep that scenario in the back of your mind as we go. So here's our game plan. We'll start with what the surgery actually is, then we'll walk through pre-op, post-op, the big complications you got to watch for, and wrap up with patient teaching. It's all designed to help you think the way the NCLEX wants you to think. First things first, what even is a hypophysectomy? Let's take a quick look at the procedure itself because, honestly, once you understand how it's done, all the nursing care that follows is going to make so much more sense. The key term here is transphenoidal. That's really just a fancy way of saying the surgeon goes in through the nose and a sinus cavity. Just think about that for a second. They're getting to the pituitary gland, which is at the base of the brain, without cutting open the skull. This is a huge deal, and it totally changes the game for post-op complications. And this right here really spells out why it's so great. You don't have a massive craniotomy incision, you have way fewer risks than old-school brain surgery, and the patient gets to go home sooner. It is a total game changer. Okay, so let's talk about our role as nurses before the surgery even happens. This is way more than just checking off boxes on a pre-op list. What we teach the patient beforehand is actually a massive safety intervention. We're setting them up for a successful, smooth recovery. Now, when you look at this teaching, it might seem a little random, right? But it's all laser-focused on one critical goal: preventing a spike in what we call intracranial pressure, or ICP. Anything that causes straining, like a big cough, a sneeze, or even the suction from a straw, can put a ton of pressure on that fresh surgical site. Super important stuff to teach. All right, the patient's out of surgery. Welcome to the most critical phase, especially when it comes to the NCLEX. The first 24 hours. This is where we really have to be on our A game with our assessment skills. If you only remember one thing from this entire explainer, please let it be this. Your number one priority, your first thought always is the neurocheck. Why? Because a change in their level of consciousness is the absolute earliest and most sensitive sign that something is going wrong. End of story. So let's break down that post-op assessment. See, every single one of these actions has a specific reason. We put the head of the bed up to keep that ICP down. We're looking at that nasal drainage for any sign of a CSF leak. We are watching their urine output like a hawk for a nasty complication called diabetes insipidus. And, of course, we're being super gentle with oral care to protect that suture line. Every action is a safety net. Being vigilant is the name of the game here. You know how the NCLEX loves to throw in a twist, right? Some complication you have to spot and react to? Well, let's get these major ones locked in your brain so you're ready for it. And there it is, the answer to our very first question. That sweet-tasting drip is the absolute textbook sign of a cerebrospinal fluid leak. This is a big, big deal, people. It's basically an open highway for bacteria to travel straight to the brain, which can cause meningitis. This is a true emergency, and you need to get the surgeon on the phone immediately. Okay, lean in close for this one because this slide is pure NCLEX gold. So the pituitary gland makes ADH, which tells your body how much water to hold on to. Surgery can mess this up, leading to two opposite problems: DI and SIADH. The absolute easiest way to remember this is DI means dry inside. They are peeing out everything. SIADH means soaked inside. They are holding on to all their fluid. If you can remember that, you can figure out the rest of the signs. You have to know this cold for your exam. Now let's look at how we manage DI. It's interesting because our approach actually changes over time. Right after surgery, in the hospital, we are being super aggressive. We're checking labs constantly, pushing fluids, and giving meds like desmopressin. But once the patient goes home, our role shifts to being an educator. We're teaching them how to manage their fluid intake and watch for signs that the DI is getting better, which thankfully it often does. And finally, we get to discharge teaching. This is so important. This is our last chance to really empower the patient with the knowledge they need to stay safe and avoid coming right back to the hospital. When it comes to long-term safety, it really boils down to three key things they absolutely have to get. Number 1, if the whole pituitary gland was taken out, hormone replacement is for life. It's not optional. Number 2, they've got to keep avoiding anything that increases that ICP for at least a few weeks. And number 3, they need to know the specific signs of hormone trouble that mean they have to call the doctor pronto.
So I'm going to leave you with one last question to chew on. If a patient is on lifelong hormone replacement, what is the one key lab value you're going to teach them they have to keep an eye on for the rest of their life? Think about it. It connects everything we've just talked about. That's the kind of critical thinking that's going to help you ace this exam. You've totally got this. Good luck.